Please unmute yourself, Morekwe.
Thank you, Beatrice, because I was talking and I had not realized that I had muted myself. I said, good evening, colleagues. It's good for me to be back. And so I will be starting the presentation today. Yesterday, I know we covered case management, the definition of case management, which was done by Dr. Beatrice, why it's important not to have fragmented services, and what it does to our clients. I know some of the participants had mentioned the fact that when you do have fragmented services, you are more likely to have our clients actually not access the service itself or get tired in terms of trying to access services that are not coordinated. Moses just covered the functions of case management, which included assessment, planning, linkages. I know I'm not saying them in the alphabetical order, advocacy, and monitoring. So today's focus, let me just put the screen. We are going to be looking at the different models of case management. Just give me a minute to share the screen with you. So I'm hoping that you can see the screen. We'll be covering models of case management. We'll not do the review because I've already just done a recap of what we did yesterday. But when you are in your respective areas and doing face-to-face, I'm hoping that you will definitely have time to discuss it individually and discuss it in groups. So now let's look at what the module actually entails. We are going to describe 4 models of case management, which are usually used in SUD treatment. Of course, there are many models, but the 4 ones that we are going to discuss are the ones that are commonly used in treatment of SUD. We are going to identify which models are currently used in your programs. As we discuss the models, we are hoping that you will be able to relate and see what component of the models you are actually utilizing in your treatment facilities or in your programs, and hopefully also identify ways in which changes may be appropriate. I know that Fatima yesterday asked a question about how do we go about it, and to me it was a clear indication that we are actually seeing how case management actually relates to where we are currently. The last objective of this module is actually to analyze your work within the context of this model. So as we discuss, it is for us to just see how is it working for us, or what components can we use to actually employ in the context in which we are working, or the different programs that you are actually running. So what are the case models that, or the models of case management that we'll be discussing? We will, hello? Okay. We are going to discuss the brokerage, or sometimes referred as to the generalist model. We'll also discuss strength-based case management model. There's the clinical and rehabilitation model of case management, and lastly, the assertive community treatment model. One of the things that I want to highlight is that even though we've highlighted these 4 models, it does not necessarily mean that in programs, people usually utilize just one. Sometimes in other programs, they use a combination of the 2, not necessarily one model in terms of case management, and it can actually be done. And I'm hoping that as we actually discuss, you can see which components of which model are you utilizing and which ones you are not utilizing, because it doesn't necessarily mean that you actually have to just stick with one model of case management in a program. Now, coming to the brokerage model, first, the definition of brokerage, what is it? It's a process of negotiating service on behalf of someone else. When you do have a broker, that person actually has a clear understanding of the services that are actually offered, and they hopefully also have a clear understanding of the services that a client actually also needs. I know in the previous curricula, in curricula 5, you saw the importance of doing thorough assessment And the information that we get from the assessments that we actually discussed in Curriculum 5 actually gives the case manager an idea in terms of which services that one can actually negotiate for, right? And usually the generalist is somebody with knowledge in a wide range of service. So when you have a case manager that is actually using this kind of model, the person actually has just wide knowledge of the range of services that are available in the community, but they are not necessarily an expert in a particular service. So it's somebody who has just a general understanding. It could be that they know where the employment services are, where housing services are, where the dentist is, where the physiotherapist is, where the clinical psychologist is, but it doesn't make them an expert in any particular field of the services that they will be negotiating on behalf of the client. Right? For this approach, the client's needs are assessed. Obviously, as I've already mentioned before, for one to negotiate on behalf of somebody, you really have to have a thorough understanding of the client. One of the things that we've discussed in the prior curricula is knowing the client's recovery capital. This is where it comes in handy in understanding what are some of the things that the client has, what is it that they lack, so that you can effectively negotiate for the service of the client. The services required are identified. Very important for case managers. I know sometimes we identify services that a client actually requires. Important to note is that you should be knowing where those services are, because sometimes when we do assessment, we identify the services that one would probably need, but it doesn't necessarily mean we know where to actually refer. So as a case manager, you not only need to know the services that are required or identified, but where to actually access those services. The client is helped to access the services in just one or two contacts. For this model of case management, you don't want to be actually giving your client to access the service like having different contacts. Let's say, for example, you want to refer a client to a clinical psychologist. You don't want to give them 5 contacts so that you don't frustrate them in the process of them trying to link or maybe trying to access those services. So usually you give 1 or 2 contacts so that if one fails or they are not able to actually access one of the service providers, there is an alternative. The significant features of this particular model is the fact that the contact with the client is very limited. The main role of the case manager is actually to just link the client with the service. And therefore, that is why it is noted that the limited duration of contact. So you are less likely to find in this model where a case manager actually accompanies the client to the service provider. The main role is just for linkages. And it is under the assumption that when you link the client with the service providers, these services are actually available in the community. Important is that as a case manager, when you link the client with the service providers, you are sure that they do exist. I know of an instance where one of the case managers, they did not update the service providers list, only to frustrate a client by linking them, and the service provider was closed for the program. So it's important to understand and to bear in mind that as a case manager using the brokerage model, you understand that there's linkages, you know about the services that the providers actually have, and whether they are still actually providing those services. There is little or no monitoring and advocacy under this model. As I've already highlighted, the main role is actually just to link the person with the service provider. So what it means when we say that there's no little or monitoring and advocacy, the case manager is less likely to know if the client actually has future problems with the other service providers that they've been referred to, right? This particular model works quite well when there is integration of services. And it will be just putting the client in touch with the system, and that will be sufficient. So you can see that when you think about linking a client with services and they are not integrated, we go back to that idea or maybe that discussion where the services are very fragmented because if you, let's say maybe you have a program and in that particular program you don't have integrated services, a physician is somewhere else, a psychiatrist is somewhere else, it will definitely come back to what we discussed yesterday about a client being very frustrated about fragmented services. So for this particular model, what works best is actually when there's integration because the case manager just links the client with the services. There are advantages and disadvantages, obviously, with the model of brokerage. The one good thing about it is that it's a quick response approach that provides immediate results to the client because what the case manager does is that it just links you with the service providers. It gives you information about the service providers, and then that's it. It's a quick way of helping a client to know where the services are actually are provided. The sole role for the case manager in this type of model is actually limited to assessment, planning, and linking. It can be seen as an advantage, of course, when you think about the fact that the case manager actually does not have extensive role as what Moses discussed yesterday. Remember, some of the functions of a case manager is advocacy and monitoring. So in this instance or in this model, there's no advocacy and monitoring. So it gives the case manager more time actually to help more clients because they do not do or conduct all the functions of case management as discussed yesterday by Professor Moses. So it is also beneficial in instances where there's limited resources, right? And because monitoring and advocacy is less, costs are lower. That is one of the advantages of the brokerage model. It does, however, work for clients that are not impoverished. I know it says not economically deprived. In that, when you send somebody to access service, maybe for example would be if you refer somebody to access service for employment, the assumption is that they would have money to actually go there and access service. If it's about online, the assumption is that that person actually has the resource to actually browse the internet to actually go to the sites if it's about employment services. So you can see that it actually works more for people that are not impoverished. It also works for people that have high levels of motivation because sometimes when we send our clients to actually access service, sometimes they do get discouraged on the way, but for this kind of model, it will work better for somebody whose level of motivation is high. And sometimes you also have to look at whether they are in early recovery or early stages of recovery, because if they are, the motivation levels is not as much as people that have long recovery. It also works well with people that have sufficient resources. Resources here, it could be physical, it could also be internal resources, as it was highlighted yesterday when you talk about internal motivation, whether it's about self-confidence. So you can see the advantage and disadvantage already in the slide for this kind of model. So some of the drawbacks in terms of looking at this model is that it is not responsive to long-term support. As I've already said, that the case manager just links the person. So some of the needs of the clients that are long-term are not really addressed. There's inadequate advocacy, as I've already mentioned. It's not appropriate for clients with late-stage SUD or in early recovery. I've already highlighted that. So let's now look at an example where we can use the brokerage model. An example would be maybe a case manager who has done extensive assessment of clients with HIV, and they have a well-integrated system for clients with HIV. The case manager would conduct an assessment and provide referrals during the initial session. And once the client is referred, the system keeps track. So you see here, the emphasis is also in terms of having an integrated system. The system keeps tracks of the client and provides ongoing service. So one of the main highlight of the efficacy of brokerage is having an integrated system in terms of referral. So the case manager hands off the client to other programs which will provide the identified service. So at the core of the brokerage model is the fact that a case manager links the client to the service, and hopefully it's an integrated service provision. So I'm going to pause for a bit and then ask you, what do you think if you were to use this kind of model in your settings, and what do you think the other providers or where you refer your clients to the other programs will think about the brokerage model? And Jessica, just help me because I can't see the participants. Just ask them to just raise their hands, and then whoever raises their hand can just say something. What do they think about the model? And what do they think if they were to use this kind of model, or if ever they are using, what would the other programs that they refer their clients to think? What do they think of the brokerage model?
Right. I'll be on the lookout for hands raised.
Or they could type it up, but it's easier for them to just to say something.
Right.
Is there anybody who uses the brokerage model or the generalist model? Anybody who can relate with this model in the programs, in the treatment facilities?
It appears Fatima would like to speak.
Okay, yeah, go ahead, Fatima.
Okay, I think what I do in my place is more or less like brokerage generally, something like that, because I don't have all the facilities. If I have a client who has a psychiatric problem, I have to refer to the psychiatrist. I have to refer people to vocation centers, you know. So when you are talking about it, I started thinking like this looks more like what I do. But when I refer people to these places, I'm sure they know that it's because I don't have these services. That's why I'm referring my clients to them. So they will always think that I don't have the services. That's why I'm referring. I don't know whether they're going to think that I'm inadequate. I don't know. Maybe they can think like that, oh, maybe our services are inadequate. That's why she's sending clients to us. But it looks more like I do in my center.
No, thank you for sharing. It will be interesting also, as we discussed, to think about like whether do you follow up, how do you know, or do you just wait for the client actually to give you information or feedback about the services that they've received from the other referral sources that you would have referred your client to. Because what normally happens is that sometimes, I know that from experience in where I work, sometimes as case managers or using the brokerage, we sometimes lack where we are supposed to follow up to just see whether what happened in the services, whether the client actually was able to access the service. We just link them up and then that's it. And hopefully, Fatima, that is not you. But it's one of those challenges because there's no advocacy, and monitoring that is a component of brokerage. So thank you for sharing. We are going to skip this slide for question because we've already answered. Our answer was Fatima. Let's move on to the second model of case management, which is obviously different from brokerage, is strengths-based case management model. For this model, it de-emphasizes the role of the case manager and other service providers in the client's life. It does focus on the client's strength, self-direction, and use of informal networks such as family and friends rather than to rely only on the agency resources. So the center, it centers around the client as opposed to the brokerage model where the case manager actually is the one in the forefront in terms of linkages. So you use the client strength actually so that they can actually access the resources themselves. So it helps clients take the lead in identifying needs, take control over the search of resources to address these needs. An example in terms of helping the clients to take lead is if, let's say, for example, I usually I will use a vocational skills. If a client actually wants to go back to school, you help them with websites, but they go into the websites, they get the information. That is how you will help the client actually get the resources as compared to the brokerage. So they search for the information or the resources themselves. The case manager actually functions as a consultant to facilitate empowerment. So in doing that, you will actually build more of self-confidence for your client when you are using strength-based, because then they are the ones that are actually doing it for themselves as compared to the case manager. And this model was initially developed by mental health system to actually help people that were receiving treatment in institutional settings so that they can prepare them for independent living. So there is more of a movement towards somebody actually doing things on their own or making sure that they facilitate that level of care. Now, with regards to the significant features of this model, it's active, it's assertive outreach to clients and goes beyond just accessing service. It's assertive in that the client actually is the one in the forefront in terms of getting resources. The case manager, though, it's firm, however, very supportive. The supportive approach that they give to the clients actually provides a platform for building confidence in a client. And there are different ways in which we can actually, our case managers can build confidence by providing this supportive approach. One of the things that you can do when we are providing support is to provide encouragement, to reinforce the things that a client does not necessarily see as strengths. Sometimes our clients come in and they have lost touch in terms of the things that worked for them. And therefore, as a case manager, you will leverage on these things so that the client actually sees them, believes in them, and obviously as a case manager, you also have to believe in them so that they can build confidence, so that they can regain independence. That's the most important thing. The other significant feature of the model is empowering clients and families by creating opportunities for growth. Remember, if we are to compare and contrast it with the brokerage, for this one, it's more extensive. So you see that there's empowerment of clients, not only clients, but families. What is of importance here is also to understand that as you empower the client, you empower the client so that they re-engage with families. So you are working with the client so that you create that opportunity for growth, education, and skill development. I'm going to go a little bit faster. The advantage is that the clients are helped to access resources for recovery based on their unique needs, right? And they also participate in terms of identifying their needs. There's significant component of advocacy that helps to destigmatize SUD. So advocacy actually also helps to destigmatize substance use disorders. There is emphasis on pathology, and the emphasis is more on the strength and capabilities of the client. When you do that, you actually also show that the client actually has potential for growth, and the client is more than just the disorder that they've been diagnosed with. There are, of course, challenges and drawbacks with all the models, and the same is true with strength-based model. Clients with late stage or very early recovery are likely not to have a lot of strengths that they can draw on from. And I want to highlight that it might not necessarily that they don't have inadequate strengths, but it might be that they are not able to see the strengths because they are in early recovery. And so it is the work for a clinician, not the case manager, to help them see that. And so and therefore, it might be difficult or maybe challenging for the client to actually use this type of a model for them to actually facilitate acquisition of resources. It works well for some, only such as those SUD has not reached severe stage. I think is the same point for clients who are well into recovery. So for clients that are well in their recovery, or who are well into their recovery, this type of model would work well, because they would be in a position to identify, to advocate for themselves, to be able to be outgoing to get the information themselves. And so that is why we are saying that, like, for those that are in early recovery, it might not be as effective as compared to the brokerage model. The advocacy and client-driven planning sometimes can cause problems with other team members. I know sometimes when we do client-centered, this also happens when other team members do not necessarily understand the type of model that you are using, and they would think that the client is just given the go-ahead, they want to do everything that they want to do. But it's not necessarily that, and therefore, it's one of the things that we should just keep in mind when working in a team, that we also make sure that all our team members understand the model of case management that we are utilizing. So here's an example just to illustrate using the strength-based model. Our client is Dasima. I don't know how you pronounce it, but it's this way that I pronounce it. Dasima has SUD related to cocaine use, has limited education, is estranged from her family, and has many friends with SUD, right? You can see some of the challenges. However, the strength is that she's motivated, right, to give up cocaine use. She's intelligent despite her limited education. She has excellent verbal skills, which could come in handy in terms of advocating for self, presents ideas persuasively, and has social contacts with non-substance using, leading to stable life. So you can see that Dasima has challenges, but she also has strengths that a case manager can leverage on. So we've already highlighted by the things that she has on. And so as a case manager, you're going to draw on her strength and address the problems identified in the intake and by Dasima herself. So we are going to identify resources that are available, presenting the options that are available, and then directing her to these resources and encouraging her to negotiate the services using her skills identified. If there is need, you would advocate for Dasima, but we've seen that she actually has negotiation skills. And what can be done? Her skills in terms of intellect and verbal skills are her core strengths, and therefore, as a case manager, you leverage on that in terms of her getting resources. Or if we are to link with her, you know that she'll be able to articulate well. You also want to encourage her to shift social focus from those with SUD. We've already identified that she actually has people that are living stable lives. You also want to encourage her to find an appropriate 12-step group from those operating in her community. This she can do well because she does have negotiating skills, right? And the one thing with Dasima is that she is eager to actually address her problem of cocaine use. If she so wishes, you also would want to encourage her to address family issues and rebuild relationships with her family. You, as a case manager, you want to continue to support and be available as a resource for as long as she needs. There are different ways in which case managers can be an ongoing resource, more when we talk about strength-based case management. You draw on the strength and allow the client to operate independently, right? So you encourage and build healthy social contact. Sometimes what you can do as a case manager is actually, because of the information that you would have gotten from your intake, from your thorough assessment, you are able to identify with the healthy social contacts that she does have or he has as a client. You want to also identify new opportunities, and this is actually unearthed by your assessment and your intake. An example of that would be employment. You also have to be in a position to answer questions about a service environment. This is very important for case managers because you don't want just to refer somebody to a service when you don't have adequate answers about the services that you are referring them to. You want to provide guidance. guidance. You want to have enough information. And sometimes when you don't have, you try to make sure that you actually go out of your way to actually get that information for the client. You have to be an encouraging person to enable the client to fully apply their strength, because our clients would need a very supportive environment. And one of the benefits of strength-based is that it does build resilience, it does build confidence in our clients, and therefore, when a case manager actually provides the support that I've just highlighted, it gives them the morale and the boost actually to continue in their recovery journey. So I don't know whether there are questions, but I was hoping that for a minute you could be thinking about the strength-based, what are your thoughts about it, and whether it's something that you actually use in your facilities. Hello? Am I talking to myself? Yes, I was saying that any thoughts about strength-based case management model? What are your thoughts about it before we get to Dr. Beatrice?
I see that it's sent though.
Okay, is my
You see what? Yes,
Okay,
Michael.
sure.
Yes, thank you and welcome. We're happy to see you.
Thank you, Michael.
Yes, I think this strength-based approach to case management may be very effective in very motivated clients with the resources you have just mentioned. But in clients who are not strongly motivated and who don't have the skills, they may be lost in transit, as it were, because they may not have the assertiveness, as it were, to negotiate these services themselves and give what is required. So I think personality characteristics are critical to determining the use of this type of case management.
Yeah.
Thank you.
No, thank you, Michael. Definitely there's need for thorough assessment in terms of what is appropriate to provide to your client. So thank you very much for your listenership, and I know that Beatrice is going to continue with the other two models of case management.
Thank
Hi,
you.
Dr. Beatrice. Yes.
Hi, Morekwe. Well done. You deserve a clap. I think we should all clap for Morekwe. Well done. Thank you. Thank you. So, thank you. I'm going to continue. I'm going to share my content. Let's see. I always forget to double click and remember this is not Zoom. Okay, so thank you very much, Morekwe. Good evening, everyone. And Morekwe has introduced us to the four models of case management extremely well. And some of your comments are actually going to be addressed in the models that are coming after that. So it's as if we are beginning with a model that assumes the client is at their best and has a high motivation with lots of strength. And we are now going downwards to where we meet the clients who have very little strengths, who have got a lot of challenges, who have little recovery capital, and who even might be in the early stages of recovery. So what Michael just shared is actually a reality. And that brings us to the next two models I'm going to discuss: the clinical rehabilitation model, and I will talk about the assertive community model. So what is the clinical rehabilitation model? This is probably what many of us do in our treatment centers, because this is where the clinical care provider also functions as the case manager. I remember hearing some of us sharing our experiences in the last class and saying that we don't have the advantage of being able to employ a full-time case manager. So it is the people who do the other functions that also serve as the case manager. So probably the counselor, the primary counselor, could also be the case manager. So when we have this kind of situation, we call that the clinical or rehabilitation model. So the clinical provider provides two roles, the role of the clinical care provider as well as the role of the case manager. So as a clinician, the counselor provides both the treatment in terms of counseling and also does the case management work. If you remember yesterday, we said that counseling is around the internal issues and the internal resources of the client. Case management is about the external resources. So now we are saying when we have the clinical rehabilitation model, this one person, whether it's a counselor, whether it is nursing officer, depending on who it is that is assigned that responsibility of providing the clinical care provider, maybe it's the clinical psychologist, that person does the counseling work, but they also do mobilization of resources, external resources for the client as a case manager. Now, the other features of this model, like we have said, is that the case manager provides clinical services and has a unique insight into the client's needs. Why? Because they are the ones that works with the client through the counseling process. So it's very easy for them to have deeper insights about the needs of the client. Even when they connect the client to the external resources, they are likely to meet the client in counseling and understand some of the challenges the client may be facing. They're able to identify the needed resources that are suitable to the client because they are working with them as their primary counselor. They also, very important, recognize the social, emotional, and mental barriers the client may encounter as they seek the external services. Now, that's a benefit this person has that the others may not, because remember, in the brokerage and the strength-based, once the case manager, leads the client to get the services they need, more or less their work ends there. But we see in this model, the case manager continues to work with the client as the clinical provider. So any barriers the client encounters in pursuit of the case management services, this person is able to pick them quickly and work on them. They also continue to work on case management issues as long as the therapeutic relationship continues. And this is the most widely used model. It's likely that it is what you're actually using. What are some of the advantages? One is that it addresses a practical problem. It's really not possible to separate clinical work and case management work for a long period of time because of the realities. For example, when you send the client to case management services, maybe outside of your institution or even within the program, but in another department, it's important that you get to know what's happening. It's important that you follow up. Now, you see, when you are the counselor, you may not have the benefit of being able to follow up because it's quite some work. So we are saying that when you combine the two, then you're able to address this simultaneously. And that is actually realistic and practical. There is also ease of receiving two services from the same individual for the client. Imagine if the client has a co-occurring disorder, you work with them as the clinician or the counselor, then you refer them to a third party who works with them as a case manager. Now, what might happen is that this client may have difficulties coordinating the services from the two. But when it's one and the same person doing it, it's easier for clients, particularly those with special needs like co-occurring disorders, women, and their many needs. It's also economical because one treatment professional provides all services as opposed to having two separate people doing the same jobs. Now, while it has all those beautiful advantages, it does have challenges or the downside. For example, for someone to do the two roles, then it means they require skills in both the counseling and the case management. So if it was the nursing officer that was doing case management, now you want them to do counseling work, then it means you need to give them training on counseling as well. So that is a challenge. There is also inadequate involvement in other roles of case management like advocacy and coordination. The reason being, this person is overwhelmed by the clinical service they are providing. So if they are doing counseling and they are doing case management, it's unlikely they will have time to do advocacy and coordination. So the case management functions actually suffer in a way. It can also be very overwhelming for this one person to handle the two roles. Now, a good example of application of clinical rehabilitation model is when we have people with special needs, like women with SUDs, because they have special needs, their own special needs, which could come from relationships. Some are affected by violence, others have children they need to take care of and they don't have housing. So when you have got women with SUDs with all these special needs, this model works pretty well for them. It also can be good for building relationships and working towards empowerment within treatment. So the fact that you work with the client in two different settings or services provision can actually strengthen the relationships and also work towards empowerment on critical issues. Now, at the same time, when you have one treatment team member handling many issues, then it gets easier to address the unique needs that the client may have, particularly if these are clients with special needs. Of course, these are questions that you can practice when you're teaching face-to-face and you have enough time to be able to practice this. Now, the final model, which is very important, is called the Assertive Community Treatment Model. ACT, as it is sometimes called, is the one that is on the other extreme, where the clients are highly dependent, their recovery capital is very low, their motivation is very low, they are probably in the early stages of recovery, and they probably have acute or severe SUD. Now, these are clients whom, like Michael was describing, you send them anywhere, they'll probably just fall off or drop off along the way. So that's why the assertive community treatment comes in. Like the name suggests, it goes beyond the individual into their community. So it's highly individualized. It is provided directly to clients in the comfort of their home and community. And the team is multidisciplinary. So the idea is, if the client can't come to you, you take yourself to the client and you provide the case management services where the client is. So you can see why it's a good model for people who are in acute need of services, people who have very little recovery capital, people who are in acute SUD or with very low motivation for recovery. The ACT team or Assertive Community team works collaboratively to provide the range of services, which can actually range from treatment to all the other support staff services. For example, it might be housing. It might be something to do with education, maybe childcare. So all these needs are addressed by this multidisciplinary team who go to the home of the client. It's provided on a 24-hour basis all day, round the year. So what we call in my country 24/7, 365 days, And so it's a very intense model of case management. Now, specific time limits and goals are established at the beginning of treatment. Why is this important? So that they can have specific tasks to achieve within certain timelines and be able to tell that by this time, this is what we need to achieve, and be able to assess whether they've achieved before they can actually now say they have achieved the purposes they wanted with that client and move on to another client. Now, what are the key features? Like we have already said, the goal is to prevent recurrent episodes of illness. This is important for clients with co-occurring disorders, to meet their basic needs, to also improve the functioning and lessen the family's burden of providing care. Now, when you have clients, for example, who have got SUD, have got co-occurring disorders that are actually recurrent or chronic, you may find that the burden on the family is very heavy. Some of these clients completely become unable to function and they're entirely dependent on the family. Even meeting their basic needs is a problem. So part of this, what this model is about, you're trying to build the client's capacity to take some level of functioning, to be able to create some level of independence and address some of their needs. Now, these services are provided to treat, for example, mental illness. It can include medications. So the psychiatrist can be part of this team, or the psychiatric nurse that visits the patient. It can also have activities like group therapy for SUD. So you might connect this client with some group that is working on a SUD. You also can train them with skills to address problems of daily living. Some of these clients struggle with what would be the basics of daily living, even just how to arrange their normal day, how to structure a day, how to manage their finances. So you will address problems as basic as those ones: management of time, management of budget. How do you handle an entire day? How do you structure a day? You can also support and do advocacy for these clients, whether it's in areas of employment, in areas of education, in areas of housing. So these are clients that you have to do much more for than the other clients in the other categories we have been talking about. Now, what challenges does this model offer? One is that it does require a trained team with diverse skills. Remember, we have said they address multiple issues, diverse issues. So if you're going to be addressing health issues, maybe psychiatric issues, you need the psychiatrist as part of the team. If you're going to be addressing counseling issues, you need the counselor. If you're dealing with issues of social welfare, you need the social worker. So it is multidisciplinary, so you need a team that is trained to handle that. The resources may be much higher. Why? Because the intensity of work that is required with this kind of clients is actually very heavy. And therefore, if, for example, you're having many caseloads or heavy caseloads or many cases, it gets to be very difficult because of the intensity of the work. You have to go to clients' homes, you're on call 24 hours, 7 days a week throughout the year. So that means that the work is much more intense. The resources may actually be higher. Of course, the need for involvement of a team. You see, you have to ensure that you have the different disciplines within your team. You may need transport to take them to the clients' homes. If it's not transport and they go by their own transport, you have to take care of that. So it has a lot of resources required, and that might be quite a challenge because of that. Now, an example that we can use ACT is when you have clients that have got diverse needs, like we said. For example, you have got people who use substances and they're homeless, they have severe mental illness, maybe they are paroles, maybe they have injecting drug use. So you can see the multiple nature of problems these clients have. Now, lots of clients who inject heroin in many countries actually fit very well in this kind of client levels. And so they would benefit a lot from using an ACT approach. Now, in the US, we are informed that the ACT teams can provide very many services. For example, they can provide SUD treatment, they can provide relapse prevention, they can help find employment, they can help with medical issues, HIV issues, among others. So this kind of clients, we can afford to only focus on the SUD. We have to intensely focus on the diverse needs. So you can also support with recovery groups where you introduce them to 12 steps groups, ensure they are attending. You can actually accompany them to attend those groups as part of the case management contact. Now we are saying that a single case manager acts as the primary contact for the client and coordinates all the services. So while it is a team that is working on this model, that team is led by a person for every client who is the case manager. And so it is that person who leads the team, who's the primary contact, and who will coordinate what every other person is doing. That helps to avoid confusion for the client. So that is basically the assertive community treatment model. As you notice, as we go down these models, they become more intense in terms of what the role of the case manager is, the client role decreases. When you think of what Monaco started with, the client takes up a heavier role, the counselor takes up a lighter role. So that tells us that depending on our client's issues, when we do assessment, we can be able to tell whether that's a client for brokerage model, a client for strength-based model, a client for clinical rehabilitation model, or a client for assertive community model. And now, because we have a few minutes, we are supposed to be stretching our legs and talking to our neighbors. So I'm going to allow you to do exactly that. You're not stretching your legs to talk to your neighbors in your house, but the neighbors in this class. So kindly share with us, based on those 4 models, which of them have you actually seen used in your country, in your programs? Anybody can raise their hand, or you can, type in the chat. Yes. Anybody?
Yes.
Yes, Fatima.
Yeah, I'm thinking that is it possible for little parts of all these models to be rolled into one? Like I'm just, as you are just continuing with the lecture, I found out that a little bit of each of the models, can be or is being used. Like you are doing brokerage, you are doing some of ACT, you are doing some of the other one, just like that. It's like they're interwoven sometimes. Is it?
Yes. Yes, I know I've lost the last part of your question, but I think what you're asking is it possible? Yes, indeed, because our clients are coming at different levels and our clients' needs are different. So yes, they can be used. There are clients that you will find it easy to use the strength-based model, for example. There are others that will require you to use the assertive community. So yes, you can actually use them for different clients depending on the client circumstances and needs. Thank you, Fatima, for that. Any other question or observation or comment on chat? Yes, Samuel. Samuel, you've raised your hand. Please unmute yourself.
Okay, Beatrice, I just wanted to say that maybe based on my training as a clinical psychologist, I'm used to the clinical rehabilitation model. And I think it seems to work for me here and a lot of the models I've seen. Maybe over here in Nigeria, we're unfamiliar with the other models as much as we are familiar with the clinical rehabilitation model. Thank you.
Thank you very much. Thank you for that. In fact, most of us use the clinical rehabilitation model. But the reason we're getting exposed to all these models is because you might discover that sometimes you use the clinical rehabilitation model for all clients when you could actually use a different model for a client who has lots of strengths and who has high motivation and who's in later stages of recovery. And that saves you time and resources for those other clients that have acute care and would benefit from the, the other models that are more intensive. And therefore, we are exposed to them so that we look at what we are using, see what is working well for us, see what is not working well, see how we can actually adopt new ideas to strengthen what it is that we are already doing. I see Tit says that they're using the clinical model. Yes, any other observation or question? Yes, I see someone has asked a question here that in co-occurring disorders cases, which is suitable or multiple model combination? I think the answer to that question really is it does depend on your circumstances and resources. Of course, the more intense the work of the case manager, the better for clients that have low recovery capital, the better for clients who have multiple problems like the one with co-occurring disorders, the better for clients who have who are in advanced stages of SUD and lower stages of recovery. So, but we have also to think about our resource base. What is it that is available for us? Because we may want to do intensive models like the assertive community model, but we may not have the kind of resources. So it's a question of balancing between the client's needs and our resources and seeing what is workable for those clients. But I think the most important point here is there are some of our clients who will not require us to do heavy investment in case management because they have got a whole bunch of strengths. They can actually take themselves, they can actually do a lot on their own with a little support, a little consultation from you, a little support from your side. And then we can reserve the many, many resources that we need for these other clients that require a lot of intense support in terms of case management. Any other question or example or comment?
I think we have someone asking you to explain the difference between the ACT manager and the strength-based manager.
The ACT manager and the strength-based manager, case management. Okay, thank you. So like Moreko said, in the strength-based case management, the client has a high level of strengths. It could be personal recovery capital, it could be family recovery capital, it could be even community recovery capital. This is also a client with a high level of motivation. They can reasonably be able to pursue services for themselves. They just need a little more of consultation so that you actually guide them where to find the services. And when you do, they actually take themselves. You might not even need to do much follow-up. They might even be the ones to give you a call and tell you, I'm doing fine. So that is the strength-based case management model. Now, in assertive community, we have the other extreme, a client who has very little strength, all right? So they have little recovery capital, whether it is personal or human, physical or human, whether it is family. So this is a client who might not even have a family, or if they have a family, the family is not supportive. So if you were to direct them to go and seek services, There's nobody they can even go with. This might be a client who even finding the resources to leave their home to come to seek your treatment is a problem. So that's the client, or the client who has multiple needs, actively using substances in severe SUD. They probably have a co-carrying disorder. Maybe they're injecting drug user. Maybe they're homeless. Now, this is not the client that will even come to seek treatment in your settings. So the case manager has to do much more and has to be very active and assertive in terms of reaching out to where the client is and almost holding the hand of the client to connect them to all the services that they require, even accompanying them to those services if need be, following up with the different teams that are required by the client. So that is the difference between the strength-based and the assertive community treatment model. So sometimes I like to think about it this way. Imagine you have 4 children. One is a little child or an infant, less than 2 years. The other one is probably 4 years. The other one is 12 years. The other one is 18. So these children are at different levels. The infant needs the caregiver intensively. So that is the assertive community. The one who's a little older, like we said, is in the age of 4, 5, 6, might need the caregiver, but not as much as the younger one. So that one does need the strength-based model because there are still a few things they can do for themselves. When they get to teenage, they actually are feeling good and have a lot of strength and freedom. So that is the strength-based client that you can actually set free, but with some guidance. And finally, we have the 18-year-old who's actually an adult, can even make decisions. That one is the one you can use brokerage. So that is the way sometimes I like to conceptualize these 4 models, that the assertive community is for the baby, the one that is entirely dependent on the caregiver. So this client is entirely dependent on you to bring the services to them. If you don't bring, they could actually die. At the top, we have the adult who can actually just be given information and they will pursue them and get the services themselves. That's the brokerage level. So that's the way I see the range of these different case management models. Any other question? Jessica?
I'm scrolling through the chat to see, but I think we've covered all of them.
Any hand that's raised?
Igator has his hand raised.
Yeah.
Igator, yes, Igator.
Yeah, thank you very much, presenters, for the wonderful presentations we are getting. I just would like to comment that in my center, we use all 4 models except the assertive community treatment. And, I think this is, obviously, this may be difficult to practice in Nigeria at the moment, because I imagine that it's going to be, it will need a lot of human resource to be able to go give treatment to people in the comfort of their home, especially when you consider that largely people have to pay for services out of a pocket.
Yes.
So it is not surprising that the ACT is something we have in all my years at the University of Benin Teaching Hospital, Mental Health Department. We have never used this.
Yes.
And the reason is very obvious. The manpower is not there. Yeah. The means of transportation and the other logistics are clearly not available. And if the hospital was to provide them, they would provide it at a fee. And looking at the kind of patient we largely have, or clients, they wouldn't be able to pay for it. I thought I should just make that comment. Thank you.
Thank you very much. I appreciate your feedback. That's very important. And when I reflect about these models, sometimes I see it this way. In our countries in Africa, sometimes we have got non-governmental organizations which get funded by development partners. Some of them don't know what work to do. We can actually encourage them to engage in these assertive community treatment models as part of the non-governmental organization work. Now, when I think about the brokerage, we have a lot of, for example, people who have trained in mental health, they're not necessarily working in treatment programs. They can actually do brokerage model where they set up outpatient centers, conduct assessment of clients, and connect the communities or the society with the treatment providers. So I kind of think even in our resource constrained countries, we can see how we can creatively innovate, how we can apply each of these models. So brokerage model can actually be a model that can be applied in an outpatient setting where a service provider who might be a counselor, who might be a psychiatrist, who might be a clinical psychologist can actually set up an outpatient clinic, and their work is to provide brokerage case management. They provide screening, they do outreach, they do screening, they do assessment, and then they refer clients to programs which can now take care of the other needs and the other case management issues, and they can do follow-up, or they can actually, because the clients at the brokerage level have strengths that they can pursue on their own, that can be done. Then, of course, like I'm saying, the NGOs, we have some of them can actually take up this work, because the advantage of NGOs is sometimes they are funded to do a range of activities. So they can actually do this kind of work and be able to engage some of the professionals that we are to support some of the activities that they do, because some of them have the ideas and the contacts to do NGO work, but they don't know what to do with their NGO. So we can actually encourage them and offer support as the professionals and support what they do. As they do their resource mobilization, we support them with technical expertise to be able to do these ACT kind of activities. So thank you very much, participants. I'm going to stop sharing now, and I'm going to be handing it over to Moses to take us to the final part of this curriculum. So Moses, please take it up. Moses, are you there?
Yeah, I'm here.
Thank you,
Beatrice and Morocco, for that very, and enlightening presentation. You've laid actually a very good foundation for me. And as Beatrice was talking, I had actually tried to experiment with the assertive outreach, using our NGO. But and a few people who could actually purchase the services we are willing, but we are hindered because of some constraint in terms of the security of our staff moving from one place to the other, and some one or two things actually hindered us from doing that. But we still have it, and we hope that we'll be able to do that in the future. We have thought of it, and my mentor has actually experimented with that community, assertive community outreach, and I was together with him, and we used to go to homes to see people and do, with a team. But when he left for England, everything died down. So that's why we couldn't continue. But we hope that we'll be able to do that in future when things stabilize in our country. And that's a very good way to actually look at it in the future. And as Beatrice said, it's easier actually for the NGOs to do it than for government institutions to carry the assertive community outreach. Thank you. You've stimulated my interest once more in this. We are going to, because this is module 4 now, steps of case management. It's a short one. These are the learning objectives for us. We describe the 6 steps of case management, but we're going to be looking at the resource pages and then try to go through them as time permits. So the 6 steps of case management as follows. 1, try to assess and know your client very well, because you can't intervene when you don't know much about your client. You must do assessment. Assessment is key. I said that before. We just completed course 5. We dealt with assessment and we spent so much time on it. And then setting and prioritizing goals. We did that too in part of it in course 5. Then developing a referral database, preparing the client for referral, following up on referrals, and maintaining referral resources. So you see, all these are 6 steps of case management, and we're going to see how we can apply them. This is supposed to be a small group presentation where we'll be able to pick one of those cases and then each step, and then a group will now work on a particular step. But we don't have that, the luxury of time to do that. So we're going to be looking into some resource page and see what we can do. So these are the resource pages. For instance, the first one has to do with assessment, which is resource 4.1. Then the second one, 4.2, setting and prioritizing goals. And 4.3, developing a referral database. And the fourth one is preparing the client for referral. And the fifth is following up on referrals, while the sixth one is maintaining referral sources. So it's supposed to be like a presentation, but we're not going to do that. Rather, we're going to go through our resource page and see how we can do that. So let me go sharing again from the resource pages and see what we can do. So a minute, please. Yeah, okay. Sorry, can you see anything? Let me switch.
Nothing right now.
Okay, okay. I'll go over it again. Sorry.
Remember to double click.
Nothing is showing up to now.
Not
Can
yet.
you see anything?
Not yet.
Wow.
Remember to double click.
Yeah, I've actually double clicked. I don't know what is happening. And I tried that. I'll go over it again.
Yeah. You can stop sharing first and then you try again.
Yeah, I've stopped sharing really.
Okay. If it doesn't work, I can open for you mine.
Let me try again. Can you see now?
Yes, there it is.
Yes.
Can you see anything here?
Yes, we can.
Yes.
Okay. So we're going for the steps now. The steps of our case management. So we're starting with 4.1, which has to do with assessment. We've done assessment, so we're not going to spend too much time on this. We're going to, just run through it and then go to the next one. So we've done assessment. For you to do case management, you must be able to assess your client, and we dealt with assessment. As I said, in course 5, and you can see here the areas which assessment is done, the background and current status. We started our SI on that, and then you go through, the past and current substance use, which we did in the SI, and then medical conditions and complications such as, injection related to medical issues, HIV/AIDS, tuberculosis, hepatitis. I went to sexually transmissible disease, liver diseases, physical disability, high blood pressure, diabetes, so on and so forth. Because most clients, when they now come down with SUD, particularly if they're the enter like they're dependent, you find that other co-occurring disorders complicate the SUDs. And It's more so when they're in the middle age and not to old age. Then you find a lot of co-occurring disorders that you need, to actually treat. And then emotional and behavioral or even cognitive status, you have to look into it. Family history of mental health problems and the history of mental health problems, including diagnosis, hospitalization. We did that in the air side, so I don't want to address so much on that. Then readiness to change. When you do an assessment and before you refer, you must know, the stage of which the client is. So where is the client in the stages of change cycle? Is it pre-contemplation or is it action or maintenance? Where is the client? You need to know that. And what is the client ready to work on? And how ready is he or she to take a step towards change? So you motivate them and make sure that they are ready for change. And then relapse, use potential related to readiness to change. How is the client managing cravings? These are usually taught, like in treatment centers, you teach them all sorts of skills, including relapse prevention. Can he or she identify personal relapse triggers as part of the treatment program? And what is the client's recovery environment? What support does he or she, have for recovery? So we're talking about recovery capital now. And then is he or she spending time with friends or family members who use drugs or alcohol? We just dealt with that, when Bisa Morocco were talking. And then does he or she, does his or her family support recovery? Sometimes the family might be a problem, and the father are the ones that might make the client relax. So you have to work, on the family to get them to support the client and be ready to have the client at home. So immediate threats to the client's safety. Is the patient expressing thoughts of suicide? You have to look into that. And threatening harm to someone else, or is he in danger? You need to, attend to all this when you are doing assessment, and you will not be setting goals when there are immediate needs, to attend to. And then suspicions of immediate danger should be investigated, asking questions. Do you feel safe at home? Do you feel safe in your current relationship? Is someone threatening you now or making you feel unsafe? So all these are things that you have to find out as you do your assessment. And general ability to function, ability to obtain and follow through on medical services, ability to apply for benefits on his or her own, obtain and maintain safe housing, skill in using social service programs, and then skill in assessing mental health and social abuse treatment services. So if he has strength in those areas, then you know how you can help or direct him or her as a case manager. And then you look at vocational skills here, 9. Basic reading and writing skills, very important for one to survive in our current world. Ability to follow instructions and ability to arrange for necessary transportation. Can the client do all those? Manner of dealing with authority, ability to be punctual, and communication skills, which are usually taught when a client is in treatment. So you have to assess all those. So conducting an assessment, some of these things I've done here. So you see, assessment is actually comprehensive. And as I keep saying, you can't intervene when you don't know the client. You only be planning for yourself and then giving directives that may not really work for the client. You must conduct a thorough assessment to be able to guide the patient and plan based on what you are able to glean from the assessment. Then you make the treatment planning together with the client and help. So let's go to the next step is what setting and prioritizing goals. And what happens here? Goals are generally statements from the client about what he or she is hoping to get out of the treatment experience. We did that in course 5. You set up your goals and then specific objectives. You have objectives which must be specific, measurable, attainable, relevant, and time limited. We talked about the SMART objectives. So this you have to do. And you also have to be able to, what would be your first or next task? You are breaking them down. You have to achieve a goal, but you're breaking them down, the goal into measurable objectives to be able to attain that goal. So what would be your first or next task, for instance? And what will you do in the next 1 or 2 days? So these are some of the things and steps you take to be able to reach your goal. And on a scale of 0 to 11, how confident are you are you that you will do this next time? So you are bringing your ruler here again. So you see all the things that you've learned, you're able to apply them here to guide the client and then treat emergencies, basic needs, and other needs. So emergencies include what? Life-threatening situations, which is serious illness, suicidal thoughts, and life-threatening withdrawal symptoms, such as those from CNS depression. Of course, sometimes people can come with very severe delirium tremens from alcohol, and they are, convulsing and it's life-threatening. You need to intervene, or even withdrawing from maybe heroin, whatever, and you need to do something about it. Otherwise, they can become violent, and so many other things can happen. And family violence, disaster situations, especially for those of us who live in this part of the world, you need to look into all this. And then employment and money, food, housing, and utilities, e.g., electricity and water, if at all they have the luxury, of having them, and then safety and transportation. Then you look at general medical care, childcare, schooling, and client goals for things that you have to do and prioritize. What would you like to work on first? What is important to the client first? Which of the objectives that we've talked about are most important to you? Which of these objectives do you think you can achieve first? So you want the client to prioritize, he help him to prioritize, and then you tackle the ones that the immediate ones, and then you can tackle the others later. Which of these objectives do you think will help you most in your recovery? So this is, ways that you'll be able to prioritize your objectives. And then a deliberate, careful approach to identifying client goals and objectives often offers benefits that go beyond actual achievement of goals. Clients benefit by one learning a process for systematically setting goals. And setting goals with the client help them to know that you don't just jump and say, okay, I want to do this. How do you get there? You must be able to break it into objectives, and you must be able to take steps to attaining your goals. And then understanding how to achieve desired goals and objectives through accomplishment of smaller objectives. Gaining mastery of the environment through brainstorming ways to overcome possible barriers to a goal objective, and experiencing the process of accessing and accepting assistance from others in setting goals and attaining them. Sometimes they don't have the skills to negotiate with other people and to seek assistance, So you help them. By the time they're going through the treatment and teaching them how to solve problems, all the social skills they need, then they'll be able to do that with your support, and you can help them to prioritize, whatever their needs are. Then developing a referral database, that is the resource page 4.3. Case managers list or database of referral resources. And these resources might be local, district, tribal, provincial social service organizations, including governmental agencies, non-governmental organizations, and faith-based organizations. These organizations should include, but not limited, treatment programs. Yes. Clients might need actually treatment, especially inpatient treatment. You must be able to liaise with those programs and be able to refer them or purchase the treatment for them. Treatment program for mental disorders. These are very important because most times, for those who are in treatment, we discovered that I said up to 60% of our clients come with co-occurring disorders, mainly mental illnesses. So you must be able to treat those. Otherwise, you will not be able to achieve your goal. And you might not even be able to cancel the client if there are other mental disorders that are interfering with the client's understanding of what you're trying to do. HIV/AIDS is something that, for those of us in treatment center, we get them very often. And as I said, in my environment, interestingly, is those who are alcohol dependent that HIV/AIDS, not even those who inject drugs. So this is our own experience, local experience. Then legal services, yes. You're able to provide legal services, family therapy services, educational and training services, family planning and other services for pregnant and postpartum women, housing programs, vocational service programs, job referral, and then programs offering general financial assistance and community peer support groups for those with SUDs, Narcotics Anonymous, AA, those living with uh, AIDS, and other special populations such as women, female, and male sex workers, and men who have sex with men. So these are things that you actually have, to do. So you see, it's something that can be very tasking. You need to be prepared, you need to plan, and you need to know who is out there offering what kind of service. I need to know how to, approach them and how to get those services for your own clients before you refer them. And most times you have to also support them and, accompany them there, as Beatrice said. So when creating a resource database, the case manager should include everything he or she knows about each organization or group, including its locations, target audience, criteria for admission, how it accepts referrals, and potential barriers. It also can help to have names of specific people to contact and to develop relationship with these people. So the case manager has all this data. And the case manager also can establish and maintain relationships with community groups, programs, other professionals, government entities, and the community at large to ensure appropriate referrals, identify service gaps, expand community resources, and address unmet needs. So when you have this data base of all services that you can purchase for your client, different services, and you know what the programs entail and what are their requirements, then you'll be able to match your clients to the various services that you want to refer them, and you'll not be embarrassed. And if you refer them and you're able to monitor and find out what's happening and also evaluate those services, you'll know whether you can refer the next client there, or you said, no, my client's needs were not met, so I'm not going to refer somebody to that service again. Or you can even call their attention, say your client needs are not met, and liaise with them and discuss the difficulties that your clients have. So keeping a database is very, very important, and that's what you do over time. In fact, it's necessary because you don't have all the services that your clients might need, so you have to liaise with other agencies and be able to purchase those services. So keeping the database is very important, and particularly if you have contact numbers, telephone number, you can call and arrange for your own client. And then preparing the client for referral. Clients need to be prepared for referral. The case manager can help a client understand the need for a particular referral and how it can help the client. The case manager also can use active listening skills to identify and acknowledge how the client is feeling about getting help. Asking for help is often one of the most difficult things a person has to do. That's very true. And people often have feelings that may prevent them from asking for help. Some common feelings include shame, fear, a sense of powerlessness, and distrust. What happens when you have a client who uh, never knew that he's HIV positive, and he came for a drug treatment, and then it begins to show signs of co-occurring disorders, infections are coming, and so many other things. And then you now, in your process of doing your routine screening, counseling and screening for different things, and then you detect that it's HIV positive, and some of these recurrent infections that is coming down with are because of the compromised immunity. Sometimes it's not easy, and when you have to refer them, some of them have this feeling of shame because, as far as society is concerned, this man is a promiscuous person. That's what my community would say. Oh, he's HIV positive. He must be a very promiscuous person. They never think that, okay, he might be infected as an innocent person. And some people in the early days of HIV, we are even infected because they were transfused with blood that was not screened. So, but once you come down with it, nobody wants to listen. Oh, they become judgmental. Oh, they stigmatize you. So that feeling of shame is there. You need to work with the client. You need to support. You need to get the service and then go with the client. And when we do that, they feel very happy. And usually our case managers stay with them, like you tell them to an HIV/AIDS clinic. You stay with them there, ensure that they get their booking. They're able to see their doctor, get their prescription, and then you bring them back to the facility. Before, and they do keep doing that until when they're discharged, then they cannot do it on their own. And they feel very happy that somebody is able to go with them. And it reduces the feeling of shame and the fear and all the apprehension and the uncertainties and the distrust that clients experience. It's very difficult, particularly in our own environment. And then cultural beliefs are also can influence how a client views asking for. Yeah. So these are things that we have to look into, and then we go down here. Education of the services the program provides, the hours the program is open, and any fees charged, and admission, so on and so forth. So these are things that you need to do and check, and then following up on referrals. When you do referrals, you must be able to follow up. Did your client, eventually get there? Was he attended to, or she attended to? Were they able to meet the needs of your clients? How was it treated? So you need to follow up. You need to find out what happened, and whether the client is satisfied or not, and even help to assess, the attitude of the staff and many things. So it's very important. We don't really have much time. So these are things that you need to do and follow. You don't just refer and relax. No, you have to follow the client. Ask how things went. Ask why a client did not use a service. They might have their reasons. Initiate another discussion of barriers. They examine how important the goal and referral are to the client. These are things that we need to do constantly. And then exchanging relevant information, summarizing relevant aspects of the client's personal and cultural background, and then contributing as part of the client's treatment team, and then coordinating all treatment and social services activities provided to the client by other resources, and periodically reviewing the client's goals and making other referrals. So this is very key, and if we're actually going to work successfully as case manager. And then here, the sixth step is what maintaining referral sources. And what are they? These are things I have. The case manager also needs to know what to send with a client. Does the program need a formal referral form? Most services here in my own place we need. Most of them, but certainly not all. And then does the client need to complete some paper before the appointment? Yes, most will require such, but the case manager accompanies. Sometimes, in fact, we go with the client or go in advance, fill those things for the client, discuss with the client, and go and do something before you not take the client and accompany them, so that you reduce the stress, for the client, and they are happy doing that. These things can change over time, and then making sure the following information in the database remains current: program, address, telephone number, contact people, types of service provided, eligibility requirements, service area, program, caseload or capacity, and referral procedure. So these are things that we need to do as a case manager. And then what else? Continuously assessing and evaluating referral resources to determine their effectiveness. You must, as a case manager, continuously actually evaluate, assess and evaluate to know whether you are actually meeting the needs of your clients or not, and then providing appropriate feedback to programs about clients' reports of their experiences. So you see, it's tasking if you are doing everything alone as a clinician, manager, and so many other things. The counselor, you may not really have the luxury of time based on the caseload to be able to do some of those things. But if you have a case manager, yeah, they may be able to do these things, more efficiently and effectively. And then making sure clients can actually access the services and keeping track of which clients seem to do best with which program, and that will help you to be able to match subsequent clients to services and add new service programs or pilot programs. So case managers also should develop professional relationships with appropriate people at other programs. These relationships can smooth the way for referrals and provide conduits for updated information about programs, services, and policies. So that's what we do, as a case manager. And for us, the case managers too are also, for instance, when we are seeing the patient, if all the therapists are doing around and want to see the patient, where we gather and discuss the patient, and get all the therapists together with the client, the case manager too is there, so that he has a first-hand information from every therapist and about what they are doing with the client and where they need to take action, and also ensure that every therapist is doing what they are supposed to be doing. So these are the most important thing, that the client, case manager does for the client. So the summary: assessing, setting and prioritizing goals and objectives, developing a referral database, preparing the client for referral, following up on referrals, and maintaining referral services. So these are the steps, of case management. It's very interesting. You need to prepare for it. Thank you very much, participants, for your active participation. I don't know whether we have time for questions or contribution, but I think we can take a minute. If you have to contribute or ask a question, please go ahead and do. So Jessica, help me out, please.
Sure, I'll be on the lookout for hands raised.
Yeah. If anyone wants to contribute, or maybe just ask a question or give their own opinion or tell us what they do, just one person, then we can call it a day. Okay, if there's none, Jessica, take over.
It seems that Chitsanzo has his hand raised.
Yeah, okay. Can you able to hear me?
Yes,
Yeah,
we can hear you.
yes, please.
Okay. I was looking at the issue of developing a database for referral. What we have seen in Malawi is that there are so many agencies out there, even the government agencies, whereby they do several services, but when it comes to helping people maybe with substance use disorders, maybe also having a mental health problem, they tend to have some kind of stigma and discrimination towards them. So when you reach out, there are always challenges, even if when you review their maybe the services they offer, the person that you are trying to refer to is eligible for that service. But because there's that kind of history that they have a substance use disorder, they have a mental illness, you see that the agency is refusing. So we kind of meet a lot of resistance, and you find that because it's you as a center referring the patient, you do all the services and then you are stuck because you can't do everything. Where I also work in a mental hospital and you combine with the university work, you find that people will just say, no, we can't do that, we can't do that. And then you find the centers getting overwhelmed with people who would have benefited from the other agencies, but the agencies are not willing to take over.
Oh, thank you very much for that contribution. Then it means that you have to do a lot of advocacy. You have to do a lot of advocacy for your own clients and also work on the stigma towards your own clients. When we started, we had similar things, but we faced a similar situation. But now it is better, and we're getting our clients, to be able to access some of those services, and they are doing well. So you continuous advocacy and engaging with all the stakeholders and that will help with time. It's not easy, but you have to persevere.
Yeah, that's work in progress. Yeah.
Okay, Jessica, over to you, please.
Okay, thanks for joining us for UTC 6, everyone. This was a fairly short section, so we only had yesterday and today, so we have tomorrow off, and we will resume UTC 7 on Thursday, if I am correct. Beatrice can confirm that.
Yes.
And
Yes.
otherwise, that's all that I have for you, and I will hand it over to her.
Thank you. Thank you, Jessica. Indeed, yes. Congratulations for completion of UTC 6, and thank you, Morekwe and Moses, for successfully taking us through that. So tomorrow we take 1 day's break. Thank you too, and then we resume on Thursday and Friday for UTC 7. It's another brief more curriculum. And then we shall now take a weekend of Saturday and Sunday. And then next week, we can be ready for an intensive week of UTC
Marathon.
8. It's ethics. It's a marathon. It's another marathon. So at least we shall have rested sufficiently. So thank you very much, Moreko. Moses, you have finished, so Moreko can say the parting shot.
Yes.
No, thank you so much. Yes, thank you. Thank you. Let me just take this opportunity because I know yesterday I joined in, but I know all of you have been praying for me. I'm back home from the hospital since last week and I'm recovering. And so I just want to say thank you for your support and you keeping in your prayers wherever you've been. So thank you. And I know that it has been a wonderful journey for all of you. I've been told in terms of participation. I see that most of us are still here after almost 2 months and a half. So congratulations to all of you. So good night.
Thank you.
Thank you, Morocco. Good to see you again.
Thank you, Molekwe.
Yes, thank you.
Good to see you.
Thank you.
Okay. So right to everybody
Good
and
night,
good afternoon
everyone.
to Jessica.
Bye, everyone. Good to see you, Marie.
Bye bye. Bye bye.
Bye.